Welcome to this self-learning module on eicosanoids. The eicosanoids are a family of small lipid-derived, locally acting cell signaling mediators that are ready-made upon demand. And they are really a fantastic example of cell signaling molecules that exemplify the complexity of receptor-ligand interactions, and they relate to every organ system in the body. In fact, this session supports both the receptor cell signaling lecture and the pharmacodynamics lecture that we'll have in Foundations. It also provides a roadmap for biochemistry, physiology, and pharmacology that I'll be covering in virtually every course after Foundations. So this session represents an initial investment that'll really pay dividends over the next 17 months of the curriculum. The term eicosanoid, besides being really fun to say and a useful way to impress people, is an umbrella term that encompasses three different subfamilies of lipid-derived mediators. These include the prostaglandins and thromboxanes, the leukotrienes, as well as a subgroup or a subfamily known as the epoxides, which we won't be discussing today. Now, by lipid-derived, I mean that they are literally reshaped and reconfigured from fatty acids that are present in the cell membrane as part of membrane phospholipids. An enzyme called phospholipase A2 cuts loose certain types of polyunsaturated fatty acids from the membrane so that they are available for making the prostaglandins, the thromboxanes, the leukotrienes, etc. This is accomplished by an enzyme, as I mentioned, called phospholipase A2. Now, the phospholipids that harbor or contain these polyunsaturated fatty acids include phosphatidylethanolamine, phosphatidylcholine, and phosphatidylinositides. These are present normally in the membrane, on the inner leaflet of the plasma membrane, and they have normal functions there, but when acted upon by phospholipase A2, they become substrates for the production of the eicosanoids. If some of these polyunsaturated fatty acids look familiar, like arachidonic acid, that's probably because they're also known as omega-3 fatty acids. You've probably heard of these. They're present in the diet. They're found in fish, meats, certain types of fruits, and they have many different important roles around the body, one of which is regulating cholesterol levels in the body. Now, phospholipase A2 is really the critical step here. It's a critical chemical switch that's responsive to environmental cues like chemical signals and cell damage, and it can toggle on and off to liberate arachidonic acid from the membrane. After this step, we'll see that it turns into a choose-your-own-adventure depending on the enzymatic catalyzed step that yields our ligands. And we have three additional enzyme levels here that I want to point out. For the prostaglandins and thromboxanes, we have an enzyme family called cyclooxygenases. For the leukotrienes, we have 5 lipoxygenases. And again, for the epoxides, which we won't be discussing much, the arachidonic acid is converted into epoxides by the action of cytochrome P450 monooxygenases. Before we get into the signaling and look at the specific types of eicosanoids, I want to take a minute to look at an overview of the types of physiological actions that these eicosanoids can influence around the body. And again, this is a summary. I'll go into specific effects later on when we talk about the specific types of eicosanoids and their respective receptors. But let's take a look so we can stand in awe of all these little lipids can do. They can sensitize sensory neurons and amplify pain, promote inflammation, cause vasodilation, affect capillary permeability, they can actually increase it and cause edema, alter platelet aggregation and blood clotting, induce fever, and promote gastric mucus production. So a lot of different actions in the body. Here we see the inner workings of the receptor-linked signaling that explain how eicosanoids, and the prostaglandins in particular, accomplish such divergent tasks. It all comes down to the types of second messengers to which they're linked. Now, first and foremost, all of the eicosanoid receptors are G-protein coupled receptors. Some of them are linked to G sub S, some G sub Q, etc. So this is one level of control over the type of action we're going to have. But you can see here that depending on the type of receptor and consequently which second messenger system is engaged, we can get different types of responses. For example, a relaxant or a contractile response, a stimulatory or inhibitory response. This is how a prostaglandin can cause vasoconstriction in one site and vasodilation in another, due to the type of receptor that it is binding. So a key here that I really want to emphasize is that a rise in calcium in a smooth muscle cell, for example, leads to contraction or constriction. So in the vasculature, this is vasoconstriction. whereas a rise in cyclic AMP leads to relaxation or dilation. So in the vasculature, this means vasodilation. You can take this one to the bank. By far, of all the eicosanoids, the prostaglandins are the most complicated. This is because there are so many different types of eicosanoids, and so many different tissues harbor their respective receptors. Our first prostaglandin that we're going to look at is PGD2. PGD2 binds to the DP1 or the DP2 receptor, as in D-type prostaglandin receptor, so it's actually intuitive. These receptors are found in places like the placenta, vascular smooth muscle, the nervous system, the retina, uterus, GI tract, eosinophils and basophils, and the lung. You'll see later on that we have drugs that mimic prostaglandin D2 action that are available for nearly all of the tissues across medical subspecialties. I'll list some of these in the final slide of this video. Next up we have PGE2, or prostaglandin E2. This, bizarrely, binds to the E-type prostaglandin receptor, and we have 4 different subflavors here: EP1, EP2, EP3, and EP4. These receptors are located in tissues such as the kidney, spleen, skeletal muscle, testes, uterus, GI tract, pancreas, the adrenal glands, the ovaries, the heart, the lung, liver, thymus, and brain, as well as polymorphonuclear neutrophils. A notable example of a drug that mimics PGE1 action at EP receptors is found in the heart with the drug alprostadil. Alprostadil is a PGE1 analog that's used for maintaining a patent ductus arteriosus, which is a congenital hole in babies' hearts, and this is used until surgery can be performed. Another example that I want to point out for PGE is the role for PGE1 and PGE2 in regulating acid production and mucus production. In fact, PGE1 and PGE2 help decrease acid production, increase mucus production, and bicarbonate production in the stomach. So we'll see a key role for these later in GI pharmacology. Lastly, we have the prostaglandin I-type, known as PGI2, which confusingly has another name. It's also known as prostacyclin. PGI2 binds to the IP receptor, or the I-type prostaglandin receptor. Now, if you're not keeping account of how many times I've said prostaglandin in the video, you probably should be. It might be worthwhile to start the video over for an accurate count. Ostensibly, PGI2 is a platelet inhibitor that's found on the wall of vessels on endothelial cells, and it helps prevent abnormal blood clotting. IP receptors are also found in other areas of the body, such as the kidney, liver, lung, spleen, skeletal muscle, thymus, heart, and pancreas. In summary, the prostaglandins can promote increases in blood flow and oxygenation by vessel relaxation. They can have opposing actions on uterine contractions, increasing or decreasing them. Also, they can have opposing actions on platelet aggregation. This is in part based on the concentration of prostaglandin and the type that we find there in the vasculature, either increasing or decreasing platelet aggregation. They also have roles in regulating intraocular pressure in the eye, decreasing it. As I mentioned, in the stomach, they can regulate mucus production. They can actually increase gastric mucus production. And finally, they can also affect the lung, increasing bronchodilation. So in summary, the summary of the summary, prostaglandins deal with blood, as in vessels and platelets, uterus, GI tract, lung, and eye. Those are the key takeaways. Next up is thromboxane, which is a type of prostaglandin. Now, I'll often refer to it as plural, which is technically correct, but there really is only one thromboxane we're going to be concerned with, and that's thromboxane A2. The receptor it binds to is known as the thromboxane prostaglandin receptor, or the TP receptor, and it's found in many diverse sites in the body, as we've seen with other prostaglandins. The platelets, vascular smooth muscle, the thymus, spleen, the lung, the kidneys, the heart, and the uterus. Hopefully you're starting to see some trends here. Most of the actions related to thromboxanes that we'll be talking about now and in the future are in the vasculature and related to blood clotting. But as always, be aware that since there are thromboxane receptors located in other sites of the body, should we administer a drug that affects the TP receptor, or thromboxane, we would be having events at these other receptors. That means adverse events. The main actions that we're concerned with for thromboxanes include its function as a potent platelet aggregating factor, its ability to increase vasoconstriction, and its ability to increase bronchoconstriction. So, the summary of the summary, thromboxanes deal with blood, vessels, and platelets principally. Let's look at a specific concrete example in the next slide that brings together the prostaglandins and thromboxanes. So here's an example that is very relevant for millions of patients around the world, that brings together the contrasting divergent actions of both the prostaglandins and the thromboxanes, and that is blood clotting regulation. So let's go through this. When there is a breach or damage to the endothelial cell layer lining blood vessels, there's a cascade of signals that's activated to form a blood clot, prevent bleeding, and initiate repair of the hole in the vasculature. It goes something like this. Normally, there are several molecules that are sequestered or hidden underneath these endothelial cells in your blood vessels. This includes collagen and von Willebrand factor. When those are exposed to the blood, they bind to platelets at specific receptors known as glycoproteins, and we'll talk about that later on in the year. Once bound, though, importantly, the platelets become activated, and they release molecules and substances that are going to activate other platelets and recruit them to this site of injury. These include many different substances, specifically for our interests, thromboxane A2. Thromboxane A2 is a platelet activator. We just saw that a moment ago in that table. You can see that here. Once it's released, it binds to a thromboxane receptor, which we know is the TP receptor, on the surface of platelets, and it activates the platelets, causes them to undergo shape changes, and we get a clot. So that's great news. But working in opposition to this, because we don't want this process to go out of control, it needs to be fine-tuned and carefully controlled. Were the clot to grow too large, pieces of it could break off and block vasculature in other parts of the body, leading to stroke and other complications that we don't want. So, as part of the normal system to control blood clotting, we also have another prostaglandin in action here. It's prostacyclin, PGI2. PGI2 is released by endothelial cells, and it binds to IP receptors on the surface of platelets, where it serves as a brake to downregulate, slow down, deactivate this clotting process, this platelet clumping process. And so I think this nicely exemplifies this divergent, sometimes antagonistic relationship that the prostaglandins have with themselves. So as previously mentioned, the production of prostaglandins is catalyzed by an enzyme called cyclooxygenase. However, I want to note that there are two forms of this enzyme found in cells: COX-1, or cyclooxygenase 1, and COX-2, or cyclooxygenase 2. COX-1 is what's known as a constitutively active or constitutively expressed enzyme. That means it's turned on all the time, working in the background. This makes sense, though, given what we've seen at this point, that prostaglandins are not just limited to inflammatory scenarios where they're flipped on when needed. This one's going all the time. COX-2, on the other hand, is the version that's flipped on in times of inflammation. So it can be activated by inflammatory mediators. These include mediators released by macrophages and dendritic cells, for example, the immunological first responders. These include mediators like tumor necrosis factor alpha or interleukin-1. So when cells see these mediators, COX-2 can become active and start generating prostaglandins that are in turn going to influence all the different physiological processes we've looked at so far. Now let's shift gears to other clinically important classes of eicosanoids, namely the leukotrienes. The major type of leukotrienes are the B-type, which bind to the B-type leukotriene receptor, or BLT. This is the receptor for LTB4. There are other types of leukotrienes known as LTC4, LTD4, and LTE4. These all bind to the cystaenol leukotriene receptor. Now, what's nice about the leukotrienes, and the story is a little bit cleaner here, that compared to the prostaglandins, these receptors are located principally on immune cells, as well as some found on smooth muscle in the lungs and in the gastrointestinal tract. So their actions are more principally directed at the immune system, so binding of leukotrienes to these receptors can yield the actions noted below: potent smooth muscle constrictors, for example in the bronchioles and the intestines. They can mediate immune cell activation during inflammation, and they can affect capillary permeability, increasing it, which leads to edema. Let's take a look at this in more detail with a specific example in the next slide. So if we start off on the upper right-hand corner, we can see that the first step in leukotriene synthesis is identical to that for the prostaglandins and thromboxanes, and that's the liberation of arachidonic acid from the plasma membrane through the actions of phospholipase A2. However, the subsequent biosynthetic steps are distinct for the leukotrienes. But before we go through this biosynthetic pathway, a bit of context. Since leukotrienes get their name because of the immune cell connection, that is, that they act on leukocytes, it should come as no surprise that the biosynthesis of these agents occurring here in this example is inside of a mast cell or an eosinophil, and that one of the targets is a leukocyte. So getting back to our biosynthetic scheme here, the enzyme 5-lipoxygenase converts arachidonic acid to the first leukotriene, LTA4. This is the substrate that's ultimately turned into the agents that are acting on cells, namely LTB4 and LTC4. Now, you don't need to worry about the enzymes that generated those, but once they're made, they're pumped out of the cell via transporters where they can bind to their cognate receptors on adjacent immune cells, for example, found on a leukocyte, or to leukotriene receptors found on tissue, such as smooth muscle. So what is the outcome of all this synthesis and signaling? Recruitment of white blood cells, physiologic changes like contraction of smooth muscle, edema, and immune cell migration into tissues. In this case, we're looking at the respiratory tract and airways, so one can imagine that this process that I've detailed here could lead to an asthmatic-like episode with mucus production, immune cell infiltration, contraction of the airways, and fluid accumulation. So, were a patient suffering from this, blocking this process would reverse these changes and give this patient relief so that they can literally breathe easy. So as we approach the end here, I just wanted to offer you a super pithy summary of some of the key sites of drug action aimed at limiting or blocking the production of eicosanoids. Specifically, we can block phospholipase A2 and the cyclooxygenase enzymes. However, as we'll see in the next slide, we have an array of eicosanoid analogs in our armamentarium, drugs that mimic their action in a very intentional way to specifically alter physiology or pathophysiology. So finally, I want to leave you with a summary of the different types of agents that are used clinically, and this really serves as a roadmap for the curriculum that I mentioned earlier. This showcases the interrelated nature of basic science material that we cover in the curriculum, as well as its clinical applicability. Now, I'll be running with you the entire year as we go through each of these courses, and we'll be constantly calling back to the basic ideas covered in this video as we encounter new eicosanoids and new eicosanoid-related drugs and see their therapeutic indications in action. Thanks very much for watching.